Acute Respiratory Distress Syndrome, otherwise known as ARDS, is something that I first encountered when I started in nursing in 2003. And I chose it as my topic today because even though it's been 14 years, going on 15 years, since I started in the nursing field, we still haven't made that much progress with ARDS. And I would think that through the years we would have really seen some improvements by now in terms of diagnosis and treatment, but it really doesn't seem to be going anywhere in all of this time. So I really want us to focus on the causes of it today and focus on what's being done in terms of trying to change treatment modalities for those that have ARDS. We're going to be looking at the different sources of ARDS, and we're also going to be looking at what treatments have been found to be effective with. There's either a pump problem, a problem with the heart, or there's a breathing problem, a problem with the lungs. When you're looking at the heart, it's one of two things. Either they've had a really bad heart attack and the body is in what they call cardiogenic shock, or they have congestive heart failure, which means they've got too much fluid, so it's just backing up and backing up and backing up and really not going anywhere. Well, there's pneumonia, and that's a big one this time of the year with flu season. There's fluid overload, like we talked about with a near drowning person, someone who has too much fluid and needs to get it off. We have barotrauma, which means trauma to the lungs itself. The lungs are bruised, therefore they're having trouble functioning properly. We have aspiration injuries, which is people that have had near drowning experiences and have swallowed too much water, have too much water on board. And then we have inhalation injuries, people that have inhaled smoke, inhaled chemicals, and things of that nature. What are the tests that need to be done? Okay, number one, easy. You're going to do a chest x-ray. That's the easiest thing because you can see what? You can see if the heart's enlarged. If it looks like the size of a basketball, it might be the problem. And you can look and see if the lungs are full of fluid and if they need a thoracentesis, otherwise being tapped in the lung to get all the fluid off. You can also do it by a CAT scan. Things don't always show up on x-ray, so you have to do a CAT scan. You can do an arterial blood gas, which is very painful, but it's where they take blood from the artery and run it in this nice little machine, and it tells you what your oxygen level is in your blood, how much carbon dioxide you have in your blood, what your overall acid level is in the body. If you've got something going on that your body's doing okay with and getting by, compensating with, or if you got something major going on that your body's going, hey, I need some help here. You can also do blood cultures, find out if it's an infection, pneumonia, anything like that going on. Blood cultures will tell you if there's something growing. Thing is, they take 3 days to grow, so that's going to take some time to get back. You can do a CBC with a differential. That will tell you the white blood cell count. That will tell you the hemoglobin and hematocrit, so you know if it's an anemia problem. It will also tell you about the neutrophils, lymphocytes, all of that to let you know if it's some kind of allergic reaction that the body has going on to something. So those can be very helpful. If the patient is conscious, a sputum culture would be wonderful. But most of the time, these people are in so much distress. They're working so hard, and they've worked so hard for so long, not even realizing that there is anything that they can do about trying to breathe easier, that we've already put them on mechanical ventilation or put them on CPAP to keep their alveoli open, that it's kind of hard to get a sputum culture. You don't want somebody spitting in the mask if they're on CPAP. That's kind of gross. However, if they're on mechanical ventilation, it's wonderful because you just have this little cup you have to attach to the tubing on the ventilator, and you can get your specimen anytime in a closed system, so you don't have to worry about getting dirty. It's great. You also, to check for the heart, need to do two things. Number one, you need to get an EKG done. Get that 12 lead picture of that heart. See if they're having an MI. See if they've had an MI and they've got extensive damage. Do a troponin. Do a CKMB. Check and see where their heart is. Then you're also going to do an echocardiogram. The echocardiogram is going to give you that ultrasound look of what's the heart look like right now. Is it overloaded with fluid? Is it functioning properly? Do we have an issue we need to address right now? Usually the first thing anybody wants to throw at inflammation is corticosteroids. But in all of the years that they have been looking at ARDS, they have found that corticosteroids are ineffective. They do not work. You can throw it at them as much as you want to, but you're wasting time that you could be doing something productive to help. They've also learned that too much fluid or too little fluid is detrimental to a patient with ARDS. They have tried prone positioning, which means laying a patient on the stomach to try to keep them from getting fluid overloaded, but they found that that really doesn't work. And what they have found is if paralytics are used, and they most likely will be used because the current thinking is if a person is on a ventilator for more than a few hours, they need to be on a paralytic so their body doesn't fight the ventilator. Paralytics will most likely need to be used for an ARDS patient because if they're going on a ventilator, they're not going to be off anytime soon. It takes a long time for them to get back where they need to be. What they've also found is that jet ventilators are better than regular mechanical ventilation. Now, if a person is just in a position that they need to keep the alveoli open, but they're not at a point yet that they need to be intubated, that moment will come. These people don't get better without ventilation that I have ever seen. But they have found that CPAP, continuous positive airway pressure, works to keep those alveoli open. They've also found that the paralytics need to be used. The paralytics, for anybody that's been intubated for more than a few hours, and I cannot stress it enough, I've seen it done in the emergency room. If you're going to paralyze somebody, please sedate them first, because nothing could be worse than being paralyzed and still well aware of what's going on around you. That would just be a worst nightmare. So please make sure they have enough sedation on board before you paralyze them. And then how are you going to check the paralysis? Train of 4. Is there anybody that does not know how to use train of 4? You've got to know that if you're going to be using paralytics. Now, antibiotics need to be started immediately to treat any source of infection. Well, how can you do that? I mean, you just told me that it's going to be 3 days before you know what's growing in the blood. So how do you expect me to use antibiotics to take care of the problem? Well, at this point, you just give something that is going to cover most bugs. There are antibiotics that just cover certain types, and then there's some that what are called broad spectrum antibiotics that cover a whole lot of them. And that's what you're going to be using at this point until you find out what your blood cultures are growing, if they're on the right thing, or if you need to change them to something else. And your sputum culture is going to tell you that too, but again, it's going to take 3 days to grow anything. And I would also hope that you would do an acid fast test and make sure that your patient does not have TB as one of the problems with that sputum culture, because that is very important to know if you're dealing with that as a source of a problem. The main thing that you need to do is the negative fluid balance. It's beneficial and it's attained by monitoring urinary output and using diuretics or dialysis if their kidneys don't function well. But I caution you, they have found that if you keep a fluid balance too negative on a patient, it causes brain damage. So be very careful. I have not seen any specific parameters as to what is the okay negative balance and where you're going to get into problems. But there's obviously a line there that has not been defined that you don't need to cross. You need to make sure if somebody's going to be on ventilation for a long period of time that you monitor closely for skin breakdown, monitor their nutrition, make sure it's adequate, make sure their pain is controlled, their sedation level is controlled appropriately, their paralytic is controlled appropriately, and that you provide DVT, deep vein thrombosis prophylaxis, either with Lovenox and or the compression hose and the compression devices on the lower legs. I prefer to have both. Then you also need stress ulcer prophylaxis. Now, I remember when I first started out as a nurse, why in the heck are we always given even Pepsid twice a day or something for the stomach? Every day. I never understood that. And I was like, why do we do it? And it makes sense if you think about it. You need stress ulcer prophylaxis in a patient who cannot eat. Because if you think about it, Lord knows they're going to go how long before they finally get an order for diet, and then it's going to be through a tube in their stomach. And then who knows how long it's going to be, because you're going to have to give them Reglan and stuff to make the gut to continue to work and push things along, and it's just hard on the body. So the easier we can make it for the body to take advantage of the nutrition and kind of reduce some of the acid when it's not getting that much nutrition, the better off you're going to be. Now, the last thing I ran across in the research was the ECMO, extracorporeal membrane oxygenation. They still use that as a rescue therapy, but they really haven't found that it does anything in terms of improving mortality rates. There's not been a whole lot of progress made with ARDS. The delineation between it being a pump problem or a breathing problem tends to guide the source of treatment. Now, paralytics should be used in a patient that is to be intubated for more than just a few hours. Why? You don't want the body fighting the vent. If the body is fighting to breathe over the vent, it's not going to get the rest that it needs to kind of recuperate because it's been working so hard. Remember, the negative balance of the fluids, the negative fluid balance, needs to be closely monitored to make sure that brain damage doesn't occur. Remember that CPAP is good until they have to be intubated. And then lastly, remember that corticosteroids are not effective with this type of inflammation in the lungs.